I'll be sure and mute it.
Okay. Just to make sure we're live, give it a few minutes. Yes, I've got an ad already.
Did you know?
There we go.
Yes. Okay, so welcome viewers. Welcome everyone to the TRT and Hormone Optimization YouTube channel. As a guest today, back with us is Dr. Jordan Grant. Welcome, Jordan.
Hey, thanks, Stephen. Good to be back.
Nice to have you. And we already had some questions in advance, 2 questions. I will first handle those and then we go to the chat box. So
cool.
Keep watching, keep posting, and we'll get to those questions.
Awesome.
First one was, Dr. Grant, what are your thoughts on using growth hormone for anti-aging benefits? Are there health risks using it? Can it be prescribed in the United States? Thank you.
That was from Andrew, I think. I think he posted that in the group. Yeah, Andrew's a good guy. I don't prescribe GH. I've looked into the technicalities around prescribing it in the US, and it seems to be really hard. I know there's clinics that do it, and I've always been curious how they kind of pull it off, if they're truly following, which I'm not a big, follow the rules guy, but when you're prescribing stuff, you have to. I don't know how they're doing it. And it's very expensive. I have seen the cost of true growth hormone. So unless you have an actual deficiency where they could maybe get your insurance to cover it, you're going to be looking at a massive cost, even for just a small 1 IU a day dose. Because it's something I was interested in the past. I think there's good, evidence that it's beneficial for skin and joint and connective tissue, sleep, those kind of things. I think it's overhyped when it comes to fat loss, muscle growth. There's, it's synergistic at high doses, especially with guys on insulin and anabolics, but at a regular low dose, you're not gonna, I think people they get excited because it's got the word growth in it and it says growth hormone. So they're gonna think maybe they'll grow muscle. It's not going to work quite like that, but it probably does have some really good benefits. And I'm curious about that. I guess my one concern, and it's not something I've looked at in a long time, is the possible insulin resistance. It's probably just at higher doses that might happen, but I feel like I've read studies in the past where there was some increase, in fasted glucose, even on a quote unquote low dose daily. So you kind of have to always think about that, right? When you're taking a hormone that your body normally produces, something like GH especially, that has so many different functions and is tightly regulated, you may be affecting pathways in a negative way, especially IGF-1 levels going up, and has that affect liver function, and mainly insulin sensitivity, I think would be my main concern with that. But, I've heard really good benefits from low dose daily. People that want to pay for it, they feel like they over time do see improvements in skin and all that. I think that'd be great if you could get it, but I don't prescribe it and I don't know how they do. So yeah, that's kind of my spiel.
Okay. VIP question 2 was, can long-term use of steroids or TRT cause short-term memory
issues, I guess?
Yeah.
I haven't seen it with TRT. I guess there's been some studies, quote unquote. They're probably more case reports with like trenbolone and Alzheimer's, right? That's the big one, yeah. Which we can't prescribe trenbolone, obviously. So I don't recommend people using trenbolone. I have used trenbolone in the past. It's one of the few anabolics that, for a lot of people, you just know it's not healthy. You can just tell by the way you feel that things are not right. And so, could that affect the health of your brain tissue? Yeah, absolutely. I would think it probably could. So for things like that, I'd be real careful. TRT, there's no studies showing that. In fact, I see cognitive improvements in guys who start TRT, or estrogen therapy, right? I've had guys that have been on Lupron or something for metastatic prostate cancer who get brain fog and their memory suffers, and they take estradiol, and within a few months they're back to thinking clearly again there's been studies on that saying, oh, no, estradiol doesn't improve memory, or it might not. I mean, it's hard to prove that stuff no matter what. There's a lot of correlation, but anecdotally speaking, I see hormone replacement as improvement in cognition. I think they've looked at, brains of bodybuilders or something. They said they're smaller over a long period of time, but bodybuilders are doing all kinds of stuff, not just taking anabolics. So you have to take that in context.
Okay, so hi, Danny Bossa. Question about the calves. Jordan already saw that.
Hey, Jordan, question for you. Why are your calves so small? Why does the vein on your forehead bulge when people talk about measuring E2? Thank you from a loyal fan. My calves are growing, I'll have you know. Calves are highly genetically determined. I don't care what anybody says, calf size, but I've come a long way. I work them 4 times a week, and why my forehead vein bulges with E2 discussions. I'm sure we'll have a few questions with regards to that. So,
okay. Globalismus, I'm on enantate 25 milligram daily shots. This gets my T up to 1200 nanograms per deciliter, free T to 27, shbg 16. When I started TRT, it was amazing, but only for about 1 week. After 1 week, all the positives stopped. Then I quit for 3 months, felt worse than before, went back on TRT, felt great again for 1 week, as if something else is missing in my protocol. My thyroid is good. DHEA is good, pregnenolone, progesterone. I have nowhere to test, but I tried pregnenolone and progesterone supplements and felt no difference. My main issue is no libido. Please help.
Yeah, and he actually just posted in the group, so we already got people responding over there. I responded to him over there as well. Just libido is so multifactorial and hard to figure out. It really is. I know, but guys don't like to hear that. I get it. People want a quick fix. There's often not. You have to look at every factor in your life other than just hormones when it comes to sex drive. You have to look at the health of your relationship, how you think about sex, right? There's cultural differences I've noticed there with how certain guys in certain cultures think about sex in general. I remember one guy one time posted in the group saying, he thought on TRT he should be walking around with an erection all day, and that's crazy. His friends had told him that. I'm like, no, that's what like teenagers and pedophiles do, right? Like you can't think about it like that. So I'm not saying he's doing that, but a lot of people you have to evaluate everything: sleep, stress, diet, and then you can start trying, to tweak. I mean, with his numbers, to me, 27 free T is not high, quote unquote. It may be too high for him. He could drop it down a hair, but you got to make small adjustments and then ride it out. And people don't like the time it takes to do that sometimes, but you have to. If he's not, I'm not a huge HCG fan, but some guys do have improved libido on it. That's something you could try. Start with a low dose, do frequent injections. I'm a big fan of more frequent injections with HCG. But again, with libido, it seems like a lot of libido is tagged to fluctuations in hormones for whatever reason. So we always talk about avoiding fluctuations for all the other benefits, but yet the libido, they seem to be able to chase it with more fluctuations. And it's sort of it's a double-edged sword. I don't have a good explanation for that. Maybe because in our bodies, when we're making testosterone naturally, we do get those daily constant fluctuations. And sex drive seems to be better in guys with normal testosterone, healthy, for whatever reason. And so I do sometimes wonder if supplementing with testosterone the way we do, which typically causes a constant level, even though it benefits all the other areas that we like, does that negatively affect libido? I don't know, because there's so many guys that still have perfect libidos when they're, so I don't have an answer for that. I wish I had something better for him, but you got to look at everything. TRT is not it just doesn't fix everything. Neither does thyroid. It can fix a lot, but not everything.
John Smith asks Dr. Grant, if someone does not have an enlarged prostate and is having trouble emptying their bladder, is there anything they can try on their own? What treatments should they discuss with the doctor? And a bit further, he asks, can you discuss the Penile implant and the safety around it?
I don't know what the Penile is. Maybe that's just a typical inflatable prosthesis. I don't know. Let's go back to the first one. If you don't okay, first of all, how do you know if your bladder emptying is caused from the prostate or not? That has to be evaluated, right? So people are under the impression that the size of their prostate, like let's say based on a rectal exam, tells them anything about obstruction from prostate, and it doesn't. So the size of your prostate, it's a misnomer when we say enlarged prostate, because people think that means the size of the gland. What we're talking about, especially in urology, is on the inside, is the prostate compressing the urethra. You can have a tiny little prostate and have complete obstruction from that. You can have a 300-gram prostate and urinate fine. So you need to be evaluated to see if there's an actual obstruction. Either urethral stricture can mimic the symptoms, so you need to have that evaluated. That would be a cystoscopy. And then you further in look at the prostate and see if there's an obvious obstruction, which is usually pretty clear. And then some guys don't have enlarged prostates, but they have a tight bladder neck. It's called primary bladder neck obstruction, where the bladder neck just doesn't relax when they go to void. And medicine can sometimes help with that, like an alpha blocker, like tamsulosin or something. Sometimes you have to go in and actually cut the bladder neck and do what's called a transurethral incision of the prostate to open that up. That can cause fertility issues because it might cause retrograde ejaculation. So you don't want to jump to prostate surgery, unless it's a really big issue. I mean, I had a guy recently, he's 39, and he actually had a pretty big prostate. I had to do an actual transurethral resection on him, but that's rare for young guys. But you need to be evaluated, because a lot of people just try to figure it out on their own, and you're just guessing at that point. There's so many things that could go into it. If you're diabetic, you could have a neurogenic bladder, right? Like where your bladder's just not squeezing. There's no medicine for that. Like you need to work on your health. And then some people, if their bladders just don't work, they have to self-catheterize. It gets complicated. So you really, I would say, don't guess on that one. If it's really something that's bothering you that much, I would definitely see a urologist to get worked up.
I Googled it, penile implant for men.
Okay, so that's what I figured. It was just a penile, because there's different brands. And they may be called something in other countries. I'm not sure. So those are a last resort. We've talked about this, I think, before on here, but a lot of urologists, sadly, if they're big implanters especially, will sell their product like it's a perfect thing. They even sometimes promise guys to make their penis bigger, which is not, it doesn't happen. Penile implant, once you go that route, you're destroying all the corpora cavernosa, the tissue. You're done. You're never going to get another natural erection again. And it's not the same as a natural erection. So when you engage the pump, the cylinders inflate, your shaft is hard, but the head is no longer full of blood. So you get this soft glands with a firm shaft, which is really can be disconcerting for a lot of guys. They think, oh, my penis is actually smaller than it was. Well, it's not smaller. It's just not as rigid, right, as it was. You're probably gonna have some sensitivity issues. You can have it's a hydraulic system, so it can break. You can get fluid leaks, fluid locks, all kinds of problems with them. They're fine if you've tried everything else, and you just, let's say you've had a prostatectomy or radiation or trauma, and or you're end-stage diabetic, and you cannot get an erection with anything else. It's reasonable, to do it. My go-to is if pills don't work, if Viagra or Cialis don't work, try an injection, try intracavernosal injections with like Trimix or Bimix or something. And that can be scary at first because guys think, there's no way I can stick a needle in my penis. But it's an insulin needle. It's 30 gauge. It's tiny. And honestly, most guys do completely fine once they've done it. They're, that's no big deal. And it works for most guys, not everybody, but it does. And you still get a nice, firm, natural erection. So I would always look into that before going, don't be sold on the penile implant unless you really know everything about it. Talk to people that have had them, and don't just buy what the urologist is selling. I'm not saying all urologists do that, but I know some that kind of oversell the IPPs. So,
Christopher, with a very difficult last name, any advice for sleep disorders and protocol?
Man, I'm not a sleep doctor at all, so obviously sleep apnea is the biggest thing we see. I mean, I see it tangentially in people that are already on CPAP, and or if I suspect they've got sleep apnea just based on stuff they tell me, always get a sleep study. It's amazing how many guys have sleep apnea, and if you can tolerate a CPAP, you pretty much feel better immediately the first night you use one. It's unbelievable. the health risks involved, the health problems involved with sleep apnea are not to be taken lightly. I think a lot of guys blow it off like it's not a big deal, but it is. And then, I need to look into this honestly, just because I'm not a good sleeper. I think limiting blue light before bed, relaxing before bed, don't drink alcohol before bed to help you sleep, because you actually don't get into a deep sleep. Taking sleeping pills, same thing. You don't actually get into the true deep sleep that you need. So you may fall asleep quicker, but I don't think you're as rested with that. So, there's all kinds of stuff you can look up online about sleep hygiene. And so that's what I would do, honestly, because I'm not an expert in sleep hygiene. I need to take my own advice more there.
Any concerns with elevated LDL around 120 while on test and nandrolone?
It's not the LDL that's the problem, in my opinion, and that's my opinion. I'm not a cholesterol causes heart disease guy. I'm more on the Malcolm Kendrick side of things, where, I think we're blaming an effect for a cause. I think when you have perturbations in your lipid profiles, especially if they're significant, you need to look deeper at liver, like fatty liver, and insulin resistance. Those would be the two things, because those are so the LDL and these are markers for something else going on. So physicians try to suppress the marker instead of the root cause, right? And so that would be more my thing. Like, what's nandrolone doing long term? How much are you taking? We don't know that kind of stuff. On TRT in general, I see people's lipid profiles improve for the most part, especially if they improve their health, do cardio, eat right, all that. A lot of this stuff can be, based around your diet, what type of diet you're eating. But I think the fear mongering over cholesterol causing the things they claim, I think, is unfounded. But that doesn't mean to ignore the numbers, because you just need to make sure your other health markers and things your tissue health is good. So.
A lot of questions are coming in, probably too much to handle all in an hour.
Yeah.
So if anyone would like to pop up their question, really give us a little super chat, then it will pop up again. But I'll pick some here and there that seem interesting. Ali Gilbert is there. Hi, Ali.
Hey, Ali.
Are there prostate massage toys you recommend, and any specific techniques you prefer, including speed thrust and number of fingers?
Always two fingers, Ali. Always. No, I don't do prostate massages. That's old school urology. Yeah.
What amount of progesterone cream is recommended for a man?
Again, that's one that I've yet to. Just so people know where I stand, I try to stay very evidence-based. I'm not against people trying things anecdotally, clinically. I just haven't gone the progesterone route yet. There's really no great research on this, right? So I know there are some places that are pushing the progesterone cream in small amounts to help with maybe libido or sleep or just different things. I just don't know enough about it. If somebody wants to link me, maybe I'm just not finding the papers. So if anybody has good data on progesterone in men and why we should use it, and how it's been used in studies, and that's fine. I haven't found the need for it. I mean, my patients generally feel pretty good, and I just wonder sometimes if people are reading a lot of this stuff online and then they get the idea, well, they're doing that, I may need to do that too. And I'm way more of a keep it simple person. Give the body what it's lacking. If you're lacking progesterone, I guess that's fine. But how do you measure that? Is progesterone, can you really measure it the way you think you can? As far as in men, especially, you're not pumping it out like women do from their ovaries at certain times, right? So we may be dealing with more of an endocrine process, just like estradiol. So how do you really know if your progesterone is low or high? That's where, trial and error can come in, I think. But yeah, I'm not a good expert on the progesterone for men. I just haven't gone that route.
Yeah, John Smith, who is a member, you can see that with a little badge next to his name. He asks, in general, how many weeks should someone wait before increasing their DHEA or pregnenolone dosage?
It's a good one. There's no hard rule on that because those are in your system pretty quickly. But I still tell people to give things at least a month. I mean, that's just my own, for that kind of stuff, for oral pills or whatever, 4 to 6 weeks in general, in my opinion, is a good time period to wait before you adjust anything. Again, I haven't seen better effects from progesterone or pregnenolone than I have DHEA. I see a lot more complaints with DHEA supplementation. I think it's trickier. Again, those are both intracrine hormones. So you're really just shooting in the dark with both of those because the blood levels do not tell you what's going on unless maybe they're super low. Like if I see a pregnenolone level that just reads less than 10, well, maybe they do have some type of systemic deficiency. I don't know though, unless you went and did radio labeled pregnenolone and looked in different tissues to see, you're not going to know. And there was a paper I posted on that in the Facebook group recently about DHEA and about the intracrine nature of it and how they were, you can't tell what the tissue levels are with the serum. So they were looking at other ways to do that with biopsies or radio labeled, markers. So it gets really complicated. But if you're just doing a trial and error, just anecdotally, I think 4 to 6 weeks is a good enough time period to know, okay, this didn't really help me and then bump it up. It just takes time to tweak this stuff and you may not need it at all. So.
Stoyan Petkov, any advice to people in their early 30s with low T and low free T that will try with their wife to conceive after a year or two, but now suffers from low T syndromes and low sperm count?
Yep. I deal with this a lot. So this is a big part, is dealing with young guys who are still trying to have children. Sadly, most clinics will just tear you off your testosterone or never start you on it if you need it. They'll put you on Clomid and just say, hope for the best. I had one of these recently. He had been, had poor sperm parameters. He's 20, 28, something like that. And so we went ahead and talked about everything. He had already been started on testosterone recently by a clinic once every 2 weeks, of course, some terrible protocol. They never told him it could suppress his sperm count even more. So we had to have that discussion. That's always important. And most guys in the group know this is a risk. So it's good to go in knowing that. But if you start on testosterone and you want to maintain, you need to get a semen analysis ahead of time, in my opinion, just to get a baseline to see where you're starting from. And then I start TRT on these guys if they truly need it. I mean, unless you can get markers, right, like gonadotropin levels, LH, FSH, like let's say you've done a steroid or SARM cycle and your levels are plummeted. Well, that would be maybe a time to try Nolvadex or Clomid, just for a short term to see if you can kind of restart things. But that's not most of the guys I deal with. In fact, a lot of these guys have actually sometimes elevated gonadotropins. I've seen a few where their FSH levels are in the high teens or 20s. It's like, well, then you don't need Clomid, right? That's not going to help you probably. So start testosterone. I still like to dial them in on testosterone alone for at least 6 weeks just to kind of see how they respond. And then we add HCG in. Then we do periodic semen analyses to make sure and see, okay, did it come up from baseline? Or if you started with a good baseline, how fast is it coming down? And you could probably do that every 6 months or so and it'll be safe. If they're trying to conceive quickly, it's more, and they have crappy sperm parameters, that's when we add follicle stimulating hormone or HMG. If they're just kind of doing it for maintenance in the future, I think just stick with the HCG. And as long as your semen, sperm parameters are decent, not falling too quickly, just ride that out and be fine. So it does get kind of tricky, but you just want to find somebody that's willing to work with you on that, because it's hard when you have low T and you feel like crap and you don't want to have sex because your libido's tanked or whatever. You just don't feel good. You don't want to start taking Nolvadex or Clomid if you don't have to, because those actually usually don't make you feel any better. They may help the numbers, but there are ways to typically maintain fertility on TRT unless you have like true testicular dysfunction, right? Like if your testicles just aren't going to respond to HCG, well, that's a whole separate issue anyway, because then you got to go into looking at sperm retrieval, cryopreservation, possible in vitro stuff down the road. There's no way to really boost that, but you need testosterone anyway at that point. You know what I mean? So it's a moot point. So yeah, you just need somebody that knows what they're doing with that.
Can you take raloxifene on TRT for gyno? Is there any case of TRT helping resolve gyno?
Yeah, absolutely. I've seen it happen. I've had guys who come in with low T and they've got gyno. I had an older guy recently who did that. He was in his 70s and he had some, little firm nipples, or growth under the nipples and a little tender, and his testosterone was low. And I said, we're going to get your free T up. We're going to get your testosterone up. And I bet you money that those regress, maybe not go away, but that they improve. And sure enough, they did. And I've had this with several patients where for some reason, they started missing doses, or they let their levels drop, and they started getting nipple sensitivity and some tenderness and all that. And we get their levels back up higher, their free T, get those androgens up, and it balances everything out, and everything regresses. And that's happened to me personally in the past. But raloxifene, I think, is fine if you do have like a sudden, let's say you already had some known gyno from maybe previous whatever. And when you're starting TRT, you're getting those fluctuations at first, and that stimulates and it becomes painful. I think a 6-week course, raloxifene or tamoxifen is fine. It's just not a long-term solution. I would never leave somebody on that. But I prefer those to aromatase inhibitors. I don't prescribe AIs. I won't do it.
What's the maximum dosage of testosterone cream you're allowed to prescribe?
No idea. There's no, it's not written down. So we titrate the symptom resolution, if some guys need 1 click a day to get their symptoms resolved, great. I've got guys that use 3 clicks twice a day, it really is about symptom resolution, and as you're documenting everything, just to make sure that that's appropriate. But I'm not worried about it. I'm not going to give somebody, 4 clicks twice a day just because they want their levels at 3,000. Like, that's not what I do. So we're talking about in the context of symptom resolution. There's no real maximum. I mean, I've got guys on injections, a couple guys that need 400 milligrams a week total just to get over 1,000 on their total T. I mean, it's rare, but it happens. So does that look like I'm prescribing too much based on somebody's arbitrary definition? Yeah, but I don't care. I just try to, as long as I document it and document their levels and their responses to certain doses, now could somebody be trying to pull one over on me just to get a higher dose prescribed? I mean, that might happen. Usually I can sniff those guys out pretty easy because I know that game. So the guys I have on 400 a week, they're not bodybuilders. They're not, they just want to feel better. And usually they're really big guys. They're bigger in general, bigger BMIs and everything. So.
I know I will be skipping a lot of questions because there's way too much coming in. Dr. Jordan is very popular, it seems. A special one there. Do your physician buddies scold you personally for being on TRT, and how do you handle that? I get scolded by my physician buddies.
Who's that from? Where is that at?
Joe6831.
Oh, I see it. Yeah. Do your physician buddies. Okay. No, I mean, I don't have a lot of physician buddies. Not really, though. I think the more people around here, at least, they kind of ask me questions. They're interested. I mean, at least if they ask, I'll talk about it. But yeah, in general, they don't scold me, but they'll scold my patients. Like some doctors around, some of them will scold them for being on TRT. But it's becoming a lot more accepted now, thank goodness. It seems to be that older generation is I don't want to say dying out, but they're retiring. But there's still a lot of strange beliefs among some practitioners about TRT. And I had one the other day, it was terrible. A guy who'd been started on TRT, is diabetic, needs to get his health in order, no doubt. But his nurse practitioner said, you have to stop TRT because you're diabetic. I was like, that's the stupidest thing I've ever heard. It's actually opposite of that. So I just don't care what other people think about me being on TRT or not. I'm very vocal about the benefits. People around here, especially like a lot of the nurse practitioners we've given talks to, they're receptive to it, because it's becoming such a common thing. They have to learn how to deal with it. But there are a lot of docs that still just blow it off. They don't give it the credit that it deserves for being a real issue. I've seen urologists, especially a lot of the private practice urologists, they make jokes about it in their forums and stuff about, what patients want, and they're trying to get dialed in, and they think these patients are just making up symptoms and making things up, and they just push pellets on them or try to get them, pre-authorized for androgel because they want their insurance to cover it. And they say, well, if the insurance doesn't cover it, we're not messing with them. They don't work with people. Most of these people aren't even on TRT, so they don't know the benefits. They don't know how it really works, and it gets frustrating from that standpoint. So I understand patients getting really frustrated with their providers for not knowing what they're doing, because it's rampant. It's everywhere. It's actually embarrassing how bad it is. I think it is probably getting a little better slowly, but it's awful. And it's not just around me, right? It's worldwide. I mean, we hear this stuff. The same stuff is everywhere. Just so, yeah. But nobody's really come at me saying you need to get off your testosterone because blah blah blah. I'm like, well, I'm healthier than I've ever been in my life, and you're not, you know. But they have misconceptions. I mean, I've talked to doctors about weight loss, and I'll start talking about calorie deficits, and the stuff they start talking, they're still thinking protein's going to hurt their kidneys and all this stuff. So they still labor under just myth. And that's what people don't understand about physicians, especially. They just repeat things they've heard a lot. It's just par for the course. I'm sure Stephen can agree. It's just common, right? It's the same thing with TRT and prostate cancer, right? There's still urologists telling people that stuff because they heard it and they were taught that, and they just repeat it. They don't look into it. It's actually worse than people can imagine. So patients need to be their own advocate. I don't give a crap about all the propaganda saying you can't do your own research if you don't have an MD. That's BS. No, research is not just Googling something, but if you actually know how to read papers and interpret them and ask questions, you can ask your provider questions when they start making ridiculous claims about your health and whatever. They say something that doesn't sound right, and you go, can you please provide me some backup for that? And they can't do it. That's a problem, right? You're in the right for asking that. Don't let them bully you. You are your best advocate. You know your health. There's lots of this online now information that we try to back up with actual, as much evidence as we can, because we don't know everything, but people are becoming savvier about this stuff. And so you need to hold your provider's feet to the fire, in my opinion, if they're telling you something that sounds like nonsense. That's for everything, not just TRT.
Yeah. I've been on conferences or in a restaurant with 20, 30 dermatologists. They're all sitting there looking really unhealthy, obese, drinking lots of alcohol. And then they look at me and they say, well, this can't be natural, right? This can't, no, that's not looking healthy.
Yeah, I know. It's unbelievable, but it makes them feel better to be in their little group, and that's just human nature.
Well, they are always way more as unhealthy docs.
Yeah, absolutely.
Yeah, they're always the majority. Is there anything guys should do to help prostate health on TRT? I know we've talked here before, but maybe a quick recap.
Prostate health is tissue health. Prostate health is total body health, in my opinion. I mean, there are some guys that can be very healthy and they still grow large prostates for whatever reason that eventually maybe become a mechanical obstruction. They probably still have some kind of unknown cause of that, like tissue hypoxia that's leading to an overgrowth of the tissue, right? And so if you're doing everything you can to be as healthy as you can, you don't need to be taking extra stuff. A lot of the prostate health supplements, in my opinion, don't do much other than placebo. Probably I would not recommend taking things that block conversion to DHT. That's not good for your health. And so just be as healthy as you can. But no, being on TRT versus not being on, and prostate health, there's no difference. TRT doesn't worsen prostate health. In fact, I would say it actually improves tissue health. Especially if you're doing all the other right things, it's going to improve nitric oxide, blood flow to the tissues. Lower urinary tract symptoms seem to get better in a lot of guys when they start testosterone replacement. So it's going to swell my prostate and all this stuff. I don't see that. I got tons of guys with enlarged prostates. We start on testosterone and they actually get better over time. It's pretty interesting.
Scanning the questions, we always get questions about how to raise SHBG and other questions how to lower SHBG. What's your thought on SHBG? Should we just leave it all alone, or?
Yeah, I mean, honestly, in my opinion, yes. I know there are ways you can manipulate it, but again, are you manipulating a marker that's not actually a problem? So it makes people feel better because, they manipulate the marker, but instead of letting the marker end up where it's going to end up based on what they're taking, right? Like, because that thing's going to change over time. The longer you're on, let's say you start with high SHBG and you take testosterone, and let's say it's at 150, something crazy. I've had one of those guys. He's just now, after a year or more, gotten down to 75 on his SHBG. by staying on his testosterone, increasing dosage to get that down. That's how you're bringing down the SHBG, but it's a byproduct of taking the testosterone. You're not trying to purposely just manipulate the SHBG. I know, and I'm probably, I mean, Gil feels different about this probably, and then Jeffrey feels a little different because people talk about taking boron and all this stuff to lower it, or changing your diet. But again, it's a transient thing to kind of manipulate that marker. When in the grand scheme of things, I think if you let things ride, SHBG is very much individually determined in a lot of ways. And there's papers on it. It's liver determined essentially. Can poor health, usually show a lower SHBG, like, insulin resistance. Those guys will have single digit SHBG, and that's true. But the SHBG is not the problem. It's just the response. It may be a proper response. That's what people kind of forget, that the body knows what it's doing in a lot of ways. And these responses and these markers change for a reason. And we try to manipulate the marker instead of addressing the actual issue. So get your liver health in order if you have fatty liver. If you're not lifting weights and at a decent body fat, do that. I mean, so much of this stuff really does go back to lifestyle, and a lot of people don't like it. I'm not saying this guy doesn't like that. I'm just saying, when I talk to patients, you tell them about the work it takes to eat right and work out and get off their pharma and all this crap that they're on, get off the statin that's worsening their insulin resistance, right? And jacking with their, all this, their hormone profile and their sex drive. And they don't want to do it, or they trust their doctor because their doctor said, you got to be on these medicines. And then you're chasing your tail, trying to fix it with other pharma, and it doesn't work that way. You actually end up making it worse. So I'm not a big fan of purposely manipulating SHBG. I think if you overcome a high SHBG just based on symptoms, you'll find the dose where you feel the best. For guys with super low, yeah, a lot of them tend to do better with more frequent administration. I think a lot of times cream actually seems to do better in those guys because you get that daily administration. Daily injections, fine, if that's what works for you. But not everybody needs that. I've got guys with low SHBG, 11, 12, 15, taking twice a week injections, they feel fine. So it's not just a one size fits all. It's not just a cause and effect thing we're dealing with here. I think there's multiple variables involved, and chasing the one thing, the SHBG, and trying to manipulate it, you're going to drive yourself crazy because then you get hyper focused on that. I see that in the group a lot with these questions because everybody wants to be fixated on labs all the time. And I think look at the bigger picture. So
a question I get a lot is, could you suggest a protocol for Postfinasteride syndrome?
Oh man, that's hard. That's a great question. I've kind of I've winged it because there's no good research on this. I've had some guys that have come to see me from far away. They've been to Mayo Clinic. They've been to other doctors we've had on the group before. Some people put them on Clomid. Some people just put them on antidepressants. There's no good, data on what to do. So a lot of these guys, in my opinion, we just tried testosterone. I mean, really. And a lot of them are younger. The cream tends to get a higher free testosterone. And so sometimes I feel like you can overcome some of these issues with the higher free testosterone level. I think sometimes pregnenolone helps these guys, but I've tried that in some of them and it hasn't done anything. A lot of them, they'll get literally 75% better just on testosterone replacement, even when their numbers are not super low to begin with, but they are generally lower after. So I do find, I mean, guys are lower in general these days anyway, so they respond well to testosterone no matter what. But a lot of these guys, the totals in the 400, 500s, their free T is fairly on the lower side. And we give it time and get them off the Postfinasteride forums. That's the worst thing I've seen for guys because there's so much bro science in those forums. They're like, oh, you need to take Proviron, you need to do this, get your DHT up. It's not the DHT. I don't think that's the issue. It's not, because those things kind of recycle and your enzymes, kind of recycle in there. So you should go back to normal DHT. It may be a neurosteroid deficiency, right? Like a lot of people think that you've affected some mechanism there. With allopregnenolone levels is the big one, but there's no affordable way to take allopregnenolone. But people think if they take pregnenolone, it's going to convert. It's not that. I don't think it's that simple. On paper, a lot of these things make sense, but we don't know that that's what actually is going on in the body. And again, so that's where winging it, honestly, and trial and error just comes in, because that's the main thing, is how do we get you feeling better safely, without masking something with like an antidepressant, which is going to lead to even usually worse sexual dysfunction. And so in my opinion, testosterone replacement alone at first is a great way to go. And there's other guys that have been through this, like Amir in our Facebook group. He's awesome. He reaches out to guys, he helps them. He probably help you deal with other issues in life that probably need to be addressed too. There's a higher anxiety in these guys that have PFS, because that's probably what drove them to take Propecia or finasteride in the first place, right? So you have to also look at the mindset. I'm sure you've seen people that, people take these things for, and I get it. Yeah, they get told, yeah, man, take this 2 milligram Propecia, you'll be fine. And they're in college, and I'm like, I get it. It sucks to be losing your hair when you're in college. I'm just now getting recession. I'm 42, so, but it's not worth it in my opinion. Some guys get away with it, and that's always the excuse, like, well, I take it on and I'm fine. It's like, okay, Russian roulette. Yeah, I'm fine 5 times and I'm not, whatever. So, but the guys that get wrecked from it, it's bad.
Yeah.
So, yeah.
Normal blood work, but low sex drive. What do you recommend?
Again, same thing as earlier. Sex drive is multifactorial. The list is honestly massive. And I don't know what normal blood work means either, right? Like, normal for one person can be abnormal for another. What was your sex drive like compared to when, right? Like, was it always like this? Is this a recent change? Has your diet changed? Diet is huge. Stress is huge. My sex drive is generally not very good until we go on vacation. Just because we have a busy life, we're always doing stuff. We're going all day long. We have lots of stress with work, all that stuff. The older you get, I think especially, really comes into play. I see it in patients, they retire and all of a sudden they're having sex with their wives 5 days a week again. But yeah, you have time and you're relaxed. You're not thinking about the jerk at work you have to argue with every day, or all the stuff, right? And once you start paying off debts, you feel better. When you're in this time of life, especially, once you get past the teenage years, stresses go up. They just do. And no amount of hormone is probably going to help that. It can help a little bit, for sure. But I think a lot of guys, they think, oh, I'll just take testosterone and I'll get my sex drive back. And it doesn't always work that way, especially for the reasons maybe we discussed earlier that I can't explain. It's just anecdotal that I have noticed libido tends to be a tricky thing when you're on testosterone. And it becomes the one thing that it's a big deal, because like you're fixing all these issues and then yet you might be worsening that one. It's like, what's more worth it to you? And I've seen guys where they say they had to get off TRT because they had no libido at all. And I get it. It depends on where you are in life and what your priorities are. And that's where I think, sometimes even if you don't have a high libido, if you're, let's say, taking a daily Cialis, you're able to get an erection easily. Then when it's time to get in the mood, let's say, and you're not at first, you will get in the mood when things are working like that. You know what I mean? It can help take your mind, because that's what I've noticed too, is when you're stressed out, maybe you're not in the mood, and then you get a partial erection, and then you get worried about losing your erection, and that just makes it worse and worse. So when you can sometimes overcome that with just a little help, from, a little low dose daily Cialis, it really does help. It helped me. And again, I don't push Cialis on everybody. It's a pharmaceutical. It's fairly safe as far as we know, but there may be other issues. But from a big picture, I think Cialis is pretty safe, especially low dose daily. You can get about 2.5 milligrams a day and get a benefit if you're healthy otherwise. So.
Mm-hmm. Is your practice accepting new patients? Do you do telemedicine? Thanks.
Yeah, so right now we do accept new patients, but if you're from out of state, you actually have to travel here. Telemedicine, we can't do out of state. The regulations are just ridiculous. I'm going to start looking into adding some states here and there. It takes forever to get a medical license in another state. Some states are easier than others. But I'm going to have to piecemeal that. They're expensive. I'll have to pay out of pocket for that myself, which is fine. Because I do want to be able to help more guys out of Texas. But right now it's just, we thought that they'd relaxed all that stuff during, 2 years ago during COVID. We were told it was fine to start just doing telemed out across state lines, and lots of providers did it. And turns out that wasn't actually really, it was like a gray area. And if you went and read the actual, every state had their own little guidelines, and you were still supposed to be getting emergency use licenses. And, you know, they all want to get their money, basically. Every state does. So there's a lot of hoops to jump through. And so right now, yeah, just, but I mean, again, a lot of guys do come see me from out of state. I mean, the way I work is, you know, it's not the typical model where you have to pay the monthly fee, which is nothing wrong with that. I'll probably do that one day when I'm out of urology. But for now, I mean, we are able to accept insurance for the office visit. So a lot of people will fly in and come see me, you know, twice a year or once a year. And we stay in contact through the patient portal. And it's even still just as affordable to do it that way. But it is a pain in the butt to travel. I get that. I wouldn't want to, right now, especially, I'm not going anywhere. So, but yeah, we do take new patients. And if you are in Texas and you want to do telemed, we do that. So.
Yeah, person asking says, thank you. I'll be relocating to Texas soon, so it would be nice to meet you in person.
Yeah, I would love it. I prefer in person if possible. I have a lot of telemed, and I like that too. But there's something nice about seeing people, especially for the first visit, seeing you face to face and just having that one-on-one is nice. You just kind of get the feel for each other better. And I become friends, you know, at least online friends with a lot of my patients. I mean, there's just tons of good guys that I've seen, and it's fun to meet them in person, you know, especially a lot of guys on the Facebook group that we've talked for years now, and then they finally come and see me. It's really fun. So I enjoy getting to meet people.
Mm-hmm. In regards to statins, do you find that in addition to TRT, patients will also have upstream DHEA and pregnenolone dysfunction and need supplementation due to cholesterol inhibition?
You know, that's a great question. I've actually never looked at it. Again, because I don't really check DHEA pregnenolone unless somebody requests it because it's endocrine. I'd be curious, though, what the correlation would be on those markers and statin use. I'm sure somebody's probably looked at that, but I've never looked at it. But that would be interesting. My main thing when guys are on statins is I really try to counsel them. And, you know, even though I can't say you got to get off your statin because I'm not the prescriber for that, right? I'm not going to pull that stuff with people. I'm going to say, here's some issues you may want to think about with statins. Kind of look into it. You can always ask your provider about it. I mean, it comes down to their decision in the end, but in my opinion, they're a terrible class of medication. There's no need to suppress such a vital molecule that's vital for everything. It doesn't make any sense. And the harms are known. They're just kind of suppressed. You know, the issues just with insulin resistance worsening. And I've seen that in people that have told me, yeah, when I got on statins, you know, I had to up my dose of metformin. And it happens, you know, for whatever reason, whatever it's affecting the pancreas. I'm not sure if it's just the tissue health in general. I don't exactly know. Again, we don't know. They don't know how most of these things work in the body. They can tell you all day long on paper, write little pictures and cartoons and show a receptor. Nobody sees that. Okay. Those are models. What they do is they have a big list of chemicals, and they start whittling them down, and they start doing things with them in petri dishes until they get some kind of effect that they want, that they deem as desirable. And then they do their human trials, and they just kind of follow and do statistics. So they don't actually really know. And I'm friends with a guy that was 15 years in the pharmaceutical industry, you know, biochemist. And we've talked about this. It's very fascinating when you boil it down, that a lot of the stuff we talk, and we speak in terms of these receptors and models, and this is doing this. And it's just a conventional way to talk about what we think may be going on, but we have no idea that that's what's going on inside a human body. So you have to be real careful when you're going to decide to take a chemical that's manipulating these markers of health or whatever that are probably going a certain way for a reason. So that's kind of my big lecture on that. So.
To preserve testicular size, don't care about fertility, what do you recommend besides HCG? Gonadorelin, short half-life issues.
Oh, yeah, the injectable gonadorelin, in my opinion, it's just the half-life. I mean, you might get away with it for testicular size. I don't know. I don't prescribe gonadorelin, but I've tried to look at studies, and, you know, the studies are always based on fertility for the most part, and they're dosing multiple times a day. I think I did see one on nasal route, and it actually did improve LH-FSH. So there may be maybe a longer half-life for the nasal if you can get it. I'm not sure how expensive that is. So that's an option. If things respond appropriately here to the gonadorelin, right? Like you have to make sure that the pituitary is going to actually respond and produce the downstream chemicals that then tell the testicles what to do. Whereas if you have functioning testicles that respond, it's kind of just easier, in my opinion, to do the HCG in small doses. So I would take as low a dose as needed to get the job done with HCG, especially if you're not worried about fertility. More frequent dosing, like I usually start guys on 3 times a week, 25 units, which is usually 250 IUs of HCG 3 times a week. And that's for fertility maintenance. Like you can kind of get away, and a lot of times with under 1,000 total weekly just for fertility. So for testicle size, I mean, you might get away with 50 IUs or a day, something like that. Might be plenty. So it's just something to explore, but I'm not a big gonadorelin or kisspeptin fan. Yeah. And I don't like Clomid. I know some guys will take Clomid alongside their testosterone and they do benefit. I don't like Clomid. I don't like any kind of poison like that. Because that's what they are. Again, they say, oh, they're selective estrogen receptor, blah, blah, blah. You don't know that. Okay. You don't know it's only affecting that. There are other effects. They're not side effects. They're just effects. Drugs just have effects. We call them side effects if it's not the effect we want to see. Right. So it's arbitrary. So you have to be careful with anything like that.
Robert Simpson says, my urologist doesn't test free testosterone or SHBG. Your thoughts on that? He said it rarely changes his clinical management anyway. Your thoughts?
I mean, it's a good question because it depends on your mindset, right? If you're going after symptom resolution, that's fine. But where it becomes a problem is if you can't get resolved, you might need to know the free T and the SHBG, because if your SHBG is 100, again, you're still going to raise the dose to get symptom resolution, but it might help you make that decision earlier if you already know that you're starting with SHBG in a crazy level. I mean, that's why I do it. It's once you're dialed in and feeling well, I usually sometimes don't check the SHBG, although our panel, it's like a 3-in-1, it's total free and SHBG. So it just comes like that. So it's easy, but it just depends on how he's managing you. I think a lot of those guys they don't really know what to do with those. Not that we know at all about that either. Because sometimes more data is not good, right? It's just paralyzing. You're like, okay, what do I do with all these numbers? What do they mean? If you titrate the symptom resolution, that's the point. But in general, sometimes data can help guide you sooner than later on those topics. So, yeah.
Simon gave us a super chat there. Can you see the question, Jordan?
Oh, yeah.
Total T 900, SHBG 105, ALT, SAT within range, bilirubin, albumin elevated, not on TRT. Recommendations for lowering SHBG without anabolics.
I would bet his free T is in the gutter with the 105 SHBG. So if everything else, bilirubin, albumin elevated, liver's probably okay with this ALT and ST okay. Bilirubin can be from a lot of factors, so you don't always have to freak out about that. Again, I haven't seen good success with naturally lowering SHBG and having symptom resolution. I just haven't, personally. You're not going to go from a free T of 6 to a free T of 20 just by naturally lowering your SHBG. It's not going to happen, in my opinion. Taking testosterone is what gets that free T to that therapeutic level. I had a guy who was similar to Simon, young 32-year-old, already had a vasectomy, so he wasn't worried about fertility, and his was about 1,000 total. His SHBG was 130, it was something crazy. And he wasn't doing anything weird. His diet was fine, everything. He just had symptoms, and we gave him testosterone, and sure enough, his total didn't change much over time. He's still around the 1,200 maybe total, but his free T went from 5 to 25 or 30, and sure enough, he felt better. And that's what matters. In my opinion. I think you're chasing your tail sometimes, especially why spend money on supplements. And testosterone is not, especially if you're done having kids, in my opinion, testosterone is actually safer and easier. That's my personal opinion on that. That's not, everybody's different. I would look at diet. If you're really trying to naturally manipulate SHBG, high carb versus low carb, and Gil's talked about, olive oil and all that stuff and fats. But higher insulinogenic diets can lower SHBG. But again, are you sacrificing other things to do that? You're just chasing that one variable, and you're going to affect a lot of other things doing that. And again, SHBG a lot of times it's going to be what it's going to be. You're not going to change the range that much, even the harder you try. So, but androgens will in general lower it over time. So, but I wouldn't just take Proviron, like a lot of people recommend, just take a Proviron on its own, just to get you're just chasing a number and you're chasing a free T, but you're not really giving your body what it needs. We don't have a Proviron deficiency. If your free T is low and you can't get it back up naturally, I mean, with health measures and all that, I think taking testosterone just makes the most sense.
Mm-hmm. We're almost at the 1 hour mark, so we're going to respect Dr. Jordan's time. So just a few more questions. One that I haven't seen before on the chat. What do you think about taking Turkesterone?
Taking what?
Turkesterone.
What the heck is Turkesterone? Oh man, now I gotta look that up. I saw somebody in Dave Lee's group mention that the other day. I thought it was a joke. Hang on. Ecdysterone. Oh, is this? No, yeah. One of those phytosteroids. So it sounds like testosterone, but it's really one of those plant-derived steroids, right? Yeah, I don't. What would be the benefits of that, I guess?
Part one.
Hang on, I gotta find where you're at. Where are you? Sorry, I lost my YouTube. I got so many things open up here. But anyway, while I'm looking, there you are. Yeah, I don't know enough about it. I've never seen good research on plant sterols and taking those kind of things to help with anything. So I can't comment on Turkish Sterol. Yeah. Dave Lee may know.
Yeah.
Latest
the guy
fad.
that is coming to relocating to Texas, he writes, it's the latest fad right now.
Oh, wow. Yeah, of course it is. Yeah. I'm not a fad person. Again, I'm not negating it may be beneficial, but fads are fads for a reason a lot of times. So I just take all that with a grain of salt. Again, this stuff's not that hard. It's really not. I think it's fun to read about, but as long as you have your bearings. But when you get online and start reading some of the stuff, it's all over the map, and you get like, oh, I want to try that, or I want to try that. And it's like, let's start with the basics. Let's start with nutrition, fitness, supplement what you need if you're low in it, like testosterone, and then just ride it out. And most guys, 99% of guys will be better that way. It really is that easy.
Just another super chat coming in on the last minutes. I'm 8 months into my TRT. Why now I am starting to get back acne?
Yeah. I mean, you may be able to answer this better than me, because, I had a guy the other day ask me that after 3 years, all of a sudden he's getting acne and he thinks it's from his TRT. I said, why do you think that would be from your TRT? Like, look at the time of year. It's holidays. You've been eating different. You're not in the sun, right? Everything's changed. That could be, I don't want to make up a cause, but why would all of a sudden it be your hormones when you've been fine?
Yeah, most breakouts happen in women as in men with changes in hormones.
Fluctuations, yep.
Yeah, fluctuations in women as well.
Yep.
Stopping a pill, changing one anticonceptive pill to another one in men too. Getting on a higher dose. Fluctuations are really what triggers acne each time again. So I have no idea if you're on a steady protocol and you're feeling fine while you have it 8 months in. So
yeah, I agree.
Probably other factors.
I would think so personally. Yeah, I agree. Because I've seen that in some patients, and sometimes you just ride things out and kind of just give it time, it goes away. So it's usually probably a lifestyle or diet factor. Because I don't think people give enough credit to how diet, especially changes as well, can affect your skin health and even outbreaks, or like you say, fluctuations. You see it in guys who so they stop HCG or something like that, and then all of a sudden they're getting breakouts, right? PCT protocols are notorious, right? Guys come off anabolics, they get on a PCT, everything drops and they break out. Like, it's just the way it is. But for somebody on a stable, steady state, nothing new, nothing changed, I would probably look at maybe something other than the TRT. That's just personally. I'm not an acne expert, but I've only had a few guys that have had issues with it. And a lot of times over time, they just prone to it, and they kind of, it regresses, but they may always have a little bit like on their back. And I know it's frustrating, but I'm not a big fan of chronic antibiotics and all that stuff. Personally, I know there's, difference of opinion on that, but just depends on how much it bothers you.
I would know how to treat it if you want to, but the real cause when you're on a steady state protocol probably won't be the hormones.
Right. Yep. I agree. So cool.
Okay, so I guess we've covered a lot of questions. I hope everyone is satisfied. I'm sure in the future, Dr. Jordan will be back and will be taking new questions as patients in real life in Texas. So thank you so much, Jordan, for doing this once again. If you anything to add to the viewers?
No, I appreciate being able to come back on. It's been a while. I need to, we should do more probably live panels, honestly, at some point, because those are always fun. Or pick a topic.
I appreciate that.
Life's busy right now for everybody. So, we got one more super chat.
Okay, so HRT 200 milligrams per week, estrogen skyrocketed. At first refused anastrozole because I heard negative things. I now take 3.5 milligrams per week and much better. Oh no, that on the just last minute, Jordan.
Yeah, no, I'm not. But you can feel better for a lot of reasons, especially if you thought your estrogen was a problem. That's a ridiculous amount of aromatase of anastrozole. So yeah, you're going to probably have to look at all other factors. A lot of guys will feel better when they take an AI because it ramps up their free testosterone pretty quickly. But over time, it comes back, everything changes, and they start feeling like crap and getting all the other issues. There's simply, you have to figure out where you feel the best on what dose of testosterone. You can't blame it on estrogen. Again, you say it's skyrocketed. You can't measure your tissue levels of estrogen. You cannot do it with a serum test. So yes, that serum number is going to go up when your total testosterone goes up. That's a no-brainer. But just because you feel better because you take something doesn't mean it's helping the thing you think it was. I hope that makes sense. That would be kind of a logical fallacy. I could start giving examples of how that works in life, but there's lots of times you can take something and feel a certain way, and then you think, well, it must have been because of this, and it's not always that. So there seems to be reasons AIs can make guys feel better, especially transiently. A lot of times it's related to how they think about estrogen. And I've dealt with that in patients. I mean, you can ask guys that I've seen who I've gotten into arguments with on Facebook, and they finally come see me because they were just the same thing you say, they were like, I've got high E2 symptoms and I take my AI and I feel better. And I'm like, you weren't having high E2 symptoms. And then we get them off their AI and everything goes back the way it was, and get them on a good protocol. And then all their high estrogen symptoms go away. And I'm like, well, what happened to your high estrogen symptoms? Like that's not what they were. Right. So I'm not saying that's what's going on with him, but a lot of times it is a belief. You can nocebo yourself into believing that a certain lab number is causing an issue when it may have nothing to do with reality. So I would never recommend anybody take an AI, especially 3.5 milligrams a week of anastrozole. You're asking for tissue health issues down the road, bone mineral loss, things like that, liver issues, in my opinion. So that's
okay.
Yep.
Thanks for that last one. Everyone watching, please give it a thumbs up, this video. We really appreciate it. And Jordan, thanks again. Talk to you next time.
Thanks, man. See ya.